Good afternoon. So I would like to introduce you to Mike. Mike is a 54-year-old gentleman who was diagnosed with myeloma in December of 2010. He presented with anemia, and his initial bone marrow biopsy showed 32% plasma cells, and his FISH showed a translocation 1114, deletion of chromosome 13, and deletion of 17p. Now, because of the deletion of 17p, he was risk stratified to be high-risk multiple myeloma. His treatment history is as follows. He was treated at an outside facility with bortezomib, lenalidomide, dexamethasone as induction. He went on to an autologous stem cell transplant and received bortezomib maintenance, progressed on that, and his local oncologist then switched him to carfilzomib. He then proceeded on to receive liposomal doxorubicin and dexamethasone and vincristine, and then presented to see us. At that time, he had progressive disease, and we placed him on carfilzomib, pomalidomide, and dexamethasone, and he went in and out of relapsing, and as you can see, he received numerous therapies. At one point, he presented with renal failure with a high Benz-Jones, and he was placed on hypercyclophosphamide, doxorubicin, and dexamethasone, and he received that for 2 cycles with treatment delays between each cycle due to prolonged pancytopenia.
So daratumumab is a drug that was FDA approved in November of 2015. It's a monoclonal antibody, again, one of these new immunotherapies that attaches to a CD38 antibody. So we have some direct effects on the cell, and it also enhances the natural killer cell activity as well. The importance of daratumumab is that it has good single-agent activity, and it's approved as a monotherapy as well, with just some dexamethasone to protect against infusion reactions. So the clinical pearls with daratumumab is that it's given weeks 1 to 8 weekly, and then starting weeks 9 to 24, it's every 2 weeks. And I always forget to say, remember, it's going to be actually 9 doses for my patients, because they say, well, no, I finished my first 8 doses, and now I can go to every 2 weeks. Well, it's actually 9, and then you go to every 2 weeks. And then you go to every 4 weeks for weeks 25 to on. In the clinical study with daratumumab monotherapy, the patients did not stop until disease progression. Just like with elotuzumab and our other monoclonal antibodies that you give for other indications, such as rituximab for lymphoma, we do recommend corticosteroids, antipyretics, and antihistamine as well as a post-med. The chance of the individual getting an infusion reaction with daratumumab is usually within the first couple of cycles of therapy. I've had it up until cycle 3. And then educating patients about the importance of herpes zoster prophylaxis is something that you should do as well.
So one of the special considerations with daratumumab is the interference with an indirect anti-globulin test. On the surface of erythrocytes, CD38 is weakly expressed. And so after a patient receives daratumumab, the drug can bind to that CD38 marker, and what can happen then is this can lead to pan-reactivity, and it interferes with ability to get a proper type-in screen when the patient needs a blood transfusion after they've received drug. This detection of irregular antibodies can be masked for about 6 months after they've stopped receiving the drug, and so it can lead to difficulties if a patient does need an emergent blood transfusion. There are solutions for this. So prior to a patient receiving cycle 1, day 1 of daratumumab, they should have an RBC genotype drawn before they receive drug. They should also be provided with a card that tells them the antibodies that were present on the RBC genotype test, and also an emergency contact number at the facility of the doctor who is prescribing the daratumumab, so that if a facility at an outside emergency center needs to get a hold of somebody urgently, they're able to do that. And then in emergency situations, they can receive O-negative blood or Cal-negative blood. And then they do require close monitoring for reactions during their transfusions. Additional considerations with daratumumab is the potential interference with laboratory tests. Antibodies can be detected in the gamma region, and if you look at the protein electrophoretic pattern on the screen, you'll see that the second large peak is present in the gamma region. 50% of the IgG kappa monoclonal bands can co-migrate with daratumumab as well as elotuzumab. And the difficulty with this is as the patient is responding to therapy, you may have actually not really be able to determine if a patient has received a CR because of the interference of the drug. The solutions for this, there's a DARA assay that is currently in development that will shift the migration of daratumumab so that you can get an accurate result, as well as there's currently in development assays for elotuzumab and isatuximab. For the DARA assay, when that becomes approved and available and in market, it would be recommended for patients who have an IgG kappa M protein less than 2 and who have achieved a deep response for the protein electrophoresis to be performed with using the DARA assay. So he received 3 cycles of daratumumab. He received it with his local oncologist, and he did well. When he came back to see us in the middle of his 2nd cycle, he said it was the best he had felt in a long time. His counts actually had improved. He started off the first cycle with a platelet count of about 75. He had improvement in his platelet count, and you'll see what dramatic response he had after 1.5 cycles of daratumumab. So if you look at the first one, he had, that's his free kappa light chain. Unfortunately, the bottom one, we switched labs in October, so I wasn't able to graph out the Benz-Jones. But his Benz-Jones prior to starting the daratumumab was around 4 to 5 grams. And after the 1.5 cycles, his Benz-Jones decreased down to about 960 milligrams, an excellent response. And in fact, he had started therapy about right the beginning of December. And so right before Christmas, his oncologist actually wrote out his light chain numbers for him on a piece of Christmas wrapping paper and gave it to his wife. And when he got home, his wife's like, he said to his wife, you know, I really wish I knew what my numbers were. And she gave it to him, and he just started crying. He was so excited. And I think this is a really good example of the hope that we have in myeloma for the new drugs that are currently in development, because here you had somebody who had had a large amount of treatment, was really becoming refractory, and a new drug comes to market, and now he's back in remission. Our plan is when he starts to progress on daratumumab is to add lenalidomide to his regimen to try and increase his T-cell response. We're going to move to Charlene now. She's a 67-year-old retired HR manager who was diagnosed with myeloma in June of 2012. She presented with 70% plasma cells and a translocation 414 and anemia. She was treated with bortezomib, cyclophosphamide, dexamethasone for 4 cycles and went on to autologous stem cell transplant and then was placed on lenalidomide maintenance for 2 years. She continued to receive pamidronate every month, and she achieved a CR while she was receiving maintenance therapy. Unfortunately, in November of 2015, she developed a rising of her light chains, and it was her 3rd increase. She felt good. She had no new lytic lesions, but she was having a biochemical relapse. She does have type 2 diabetes and is insulin dependent and has some peripheral neuropathy. Her family history was significant for diabetes, and she takes an aspirin once a day. So just like the patients that Donna presented, she has a lot of treatment options at this point. She has ixazomib, she has carfilzomib in combination, pomalidomide in combination, bortezomib in combination, as well as elotuzumab, and then other clinical trials. She only lives 15 minutes from the medical center, so she lives close. She has good family support as she lives with her adult daughter and her 2 teenage children. And so we discussed all the options. And I think that, you know, patients can get very overwhelmed because I think the fortunate thing in myeloma is we do have a lot of options, but on the other side of that, there are a lot of options. And so patients are always like, oh my gosh, you're just throwing a lot at me. But I think it's important that when you're talking with patients that you talk about the most significant side effects and then what's acceptable to them. And for her, she had talked about the peripheral neuropathy, and so she wanted to go with a carfilzomib-based regimen.
So the ASPIRE trial looked at carfilzomib, lenalidomide, and dexamethasone, a 3-drug regimen with again, this is a proteasome inhibitor based with an IMiD based, compared to lenalidomide and dexamethasone was the standard of care. And that was given in clinical trials to people with 1 to 3 prior therapies. And this was a large trial with 792 patients. What we saw was a higher overall response rate, 87.1% in people that got the 3-drug combination with that carfilzomib, lenalidomide, and dexamethasone versus 66.7% in the patients that just got lenalidomide and dexamethasone. We also saw deeper response rates. We talked earlier on about the importance of that deep response, and we saw that here in this trial as well. It also showed in this study the improved progression-free survival and overall survival, which is shown on this slide. Progression-free survival with the 3 drugs was 26.3 months versus 17.6. And these are all important things for nurses to be aware of, because the patient will say, will this work and how well will it work? We have all these drug therapies available in 1 to 3 prior lines: the Activism, lenalidomide, dexamethasone, elotuzumab, lenalidomide, dexamethasone, carfilzomib, lenalidomide, dexamethasone, and all of these therapies have different response rates and different side effects. So we take into consideration, think of your little, I call them the Olympic bubbles, with the patient preference and the clinical decision-making that you have to take into consideration what the patient wants as well. Now, carfilzomib is typically given back-to-back dosing days 1, 2, 8, 9, and 15 and 16 of a 28-day cycle. In the study, the KRD regimen, which is carfilzomib, len-dex, you received the lenalidomide, as you can see on the study calendar as an example. For 21 out of 28 days would be the lenalidomide, and then the dexamethasone would be weekly days 1, 8, 15, and 22. So think about adherence and how you're going to describe to your patients how to take this regimen, and a calendar is typically a good way of doing it. So while we're talking about carfilzomib as a good therapy, it was FDA approved in 2012 by itself, and now we have all these different studies with carfilzomib that shows it can be effective when compared against other things. So in the Endeavor trial, which compared carfilzomib dex, a 2-drug, to bortezomib dex, a 2-drug, we saw that in patients with 1 to 3 prior therapies, it was 929 patients, so it's a large study. The KD dose was 56 milligrams per meter squared, so this is a lot higher of a dose than the earlier trial. And it was compared to standard dose of bortezomib dex, which was considered the standard of care. The duration of response was better at 21.3 months versus 10.4 in just the bortezomib dex group, and a higher overall response rate of 77 versus 63%. So again, the take-home point is it's a high dose of the carfilzomib. Some of the considerations with the Endeavors trial, though, we did see, again, the progression-free and overall survival was better, but some of the considerations would be the side effects, such as the increased risk of blood clots. We don't think of proteasome inhibitors as causing it, but in this study, we saw a little bit of an increased risk of blood clots in the carfilzomib groups. So again, think about the risk of blood clots as myeloma being an inherently coagulable disease as well. Think about the risk of peripheral neuropathy as well as the routine monitoring.
So when carfilzomib is given in combination with dexamethasone at the higher dose range, it's given in the same standard dosing schema on 1, 2, 8, 9, 15, and 16. It's important to remember that whenever starting a patient on carfilzomib, that you're going to start at the 20 milligram per meter squared dose for days 1 and 2, and then if tolerated, increase them to 56 milligrams per meter squared. The dexamethasone is given 20 milligrams on the days of carfilzomib, and it should be given prior to the patient receiving the carfilzomib. And it should be given at least 30 minutes before, but you can also have them take it several hours before as well. So with carfilzomib, the important points to remember is to avoid starting it at the end of the week, particularly the first cycle. Our patients who are receiving carfilzomib for their first cycle, I usually dose them on a Monday or Tuesday so that if they develop any dyspnea, which we can sometimes see with carfilzomib, there's a clinician that they can get in touch with. I don't like to dose them on a Thursday or Friday, Saturday, just because if they get somebody who's on call who's not as familiar with the drug, they may get to give them inaccurate information. You want to use hydration cautiously in patients who are more sensitive. So again, looking at your patient, do they have heart disease? Do they have CHF? What is going on with them? So you just really want to be careful. If they do have cardiac history, you really want to consult with their cardiologist, get a baseline echocardiogram and EKG prior to starting it, and make sure they're cleared from the cardiology standpoint prior to starting carfilzomib, because while the cardiac events are rare, it's less than 5% of patients, they can occur. You want to monitor for infection with any of the regimens. It's important to reiterate to patients that they need to go to the ER for fever, particularly if it's greater than 100.5. And I know patients don't like to go to the ER because you have to wait so long and all those types of things. But it's really important that they know when they need to go to the ER. They should receive aspirin prophylaxis. On this study that Beth talked about, they did see a higher incidence of clots at the higher dose range, so that would be important as well. They should be on herpes zoster prophylaxis with either acyclovir or valcyclovir. It's important that they know that they need to take that every day and not just stop after like the 1 month supply, because sometimes patients are like, oh, well, I just thought I had to take it for the month, and you're like, no, you need to keep taking it. And then you want to use diuretics if they do get fluid overload, but again, assessing your patient. So Charlene received 3 cycles of therapy and achieved a partial remission, and after 5 cycles, achieved a very good partial remission. And she's going to continue on treatment. We did eliminate the dexamethasone pre-medication because she had been doing well and not having any side effects. We're continuing her supportive care, so you want to make sure that as patients are continue on therapy, that you're ensuring that they're taking their herpes zoster prophylaxis. I find that I have to ask them each month because sometimes they just forget that they're supposed to be taking it. Like all of a sudden, like we're not going to have them take it anymore. And then making sure that they're staying up to date on their health maintenance. You know, sometimes when patients get cancer, they think that because they have one cancer, that means that they can't get any other cancers, and that's not true. We all have patients who have more than one cancer. And so it's important that they know that they still need to stay up to date on their mammograms, their pap smears, their colonoscopies, and if it's a male, their prostate exams. They also sometimes seem to forget that if they do have heart disease, that's not so important as their myeloma. So you need to make sure that they're keeping in contact with their cardiologist and seeing their primary care provider. And then as Beth mentioned before, maintaining good weight control and exercise and all those things that are going to keep us healthy. We're going to move to the next case study, Roberto. He's a 71-year-old gentleman. He is a business owner. He was diagnosed in January of 2013, and he had 50% plasma cells at that time. He had standard risk disease as he had no poor cytogenetic markers. He did have lytic lesions to the skull and to the ribs. He had a history of atrial fibrillation and some mild pulmonary hypertension, and he received bortezomib, lenalidomide, dexamethasone for 8 cycles, followed by len maintenance for 2 years, and he achieved a complete remission. In November of 2015, though, he developed pain to the ribs as well as fatigue, and so he was found to have new lytic lesions on bone survey to the skull and to the ribs, and he also had an elevation of his free light chains. And so he was found to have relapsing disease. Now remember, he has atrial fibrillation and mild pulmonary hypertension, and so that's going to be important when we're talking about treatment options for him. Just like the other patients that we've had in our case studies, he also has a large variety of treatment options available to him. He is married, he travels frequently, he does not like to stay in one place at any one time. He spends his summers up north, and he visits his kids and grandkids and who are located in multiple states. He's a non-smoker, and so for him, the biggest thing for him was that he wanted something that he did not have to be tied to an infusion therapy center. He wanted to be able to take his medicine with him and not have to worry about like, okay, I've got an infusion on this day and this day and this day, or an injection. So he really wanted to be able to just take his medicine with him and go.
So Roberto started on pomalidomide and dexamethasone, and this is an oral immunomodulatory drug, and this is what we call a doublet or a 2-drug combination, because we saw in a clinical trial in patients who received 2 prior therapies, including bortezomib and an immunomodulatory drug, that it was superior when taken in combination with dexamethasone. And that was recommended low-dose dexamethasone, which is about 20 milligrams in the clinical study if you were over 75 years of age, or 40 milligrams if you were less than 75 years of age. Pomalidomide should be taken without food 2 hours before, 2 hours after a meal, and we tend to recommend it in the evening as well. We're not supposed to crush, chew, or open capsules, and as it's an immunomodulatory drug such as like thalidomide and lenalidomide, we also have that REMS program to protect against pregnancy. So this slide illustrates some clinical pearls in patients that are on oral pomalidomide, such as monitoring blood counts. Neutropenia is the most common grade 3-4 adverse event, and that can occur more likely in the beginning when they're starting therapy. We also want to look for liver function and response. We want to make sure in somebody like Roberto, who's just on 2 drugs, that it's actually working to control his myeloma so he can go in summer in Ohio and winter in Houston or wherever he's wintering. Sounds so exotic, right? Wintering and summering. So we want to be proactive in the adverse event management. Fortunately, pomalidomide does not have a lot of adverse events. It's generally well tolerated. We want to make sure if, Roberto doesn't smoke, but if your patient does smoke, it can interact, and maybe that's a way you can get them to stop smoking because it reduces the exposure of pomalidomide with cigarette smokes. Also want to protect renal health. Roberto might be driving, and I know when I travel, I don't drink a lot of WIC goods because I don't want to have to stop and go to the bathroom. We want to make sure that Roberto is drinking adequate amounts to protect his kidneys and prevent him from getting blood clots, because you're more prone to get blood clots when you're dehydrated. Also want to avoid NSAIDs to protect his kidneys, IV contrast dries, and be conscientious of other drugs that can affect the kidneys. So this is an example calendar similar to the other calendars we've showed, and hopefully you'll be able to adapt some of these for your practice. Pomalidomide is given typically a 4 milligram dose, days 1 through 21 of a 28-day cycle, and weekly dexamethasone. I mentioned earlier that there's a reduced dose. Elderly individuals don't do well with high doses of dexamethasone, and in studies such as this one, we saw that a 20 milligram dose weekly, they did better in terms of quality of life and less infectious complications. So it is weekly on days 1, 8, 15, and 22.
And so he returns in follow-up. He had noted that he tolerated therapy well. He achieved a very good partial remission after 4 cycles, and he had excellent adherence. I think his case demonstrates the importance of coordinating care with multiple providers. Mm-hmm. We had to coordinate care with his oncologist in other states so that he would be able to receive his pomalidomide as well as have his counts checked between when he wasn't in Houston. The importance of making contact with the cardiologist and pulmonologist as well, and then also maintaining the primary care provider within that loop. And the nurse, I know for us, our nurse really helps us to stay on track in our clinic. I think that we would be completely lost without our nurse, and she really helps to kind of tie our team together, and then also helps us to be able to get in contact with the other team members that aren't at MD Anderson.
I just wanted to take a moment at the very beginning. We talked about the International Myeloma Foundation's Black Swan Research Initiative, and it started from the idea in the 1600s. The first black swan was found, and before that, you didn't think there's no such thing as black swans. They're all white swans. Well, that's not the case, and that kind of sets the stage for myeloma in 2016. We didn't think a cure would be at all possible. Now we have all these drugs with these deep response rates. We saw an earlier case study that was planned to do a bone marrow biopsy just out of pill therapy, no transplant. So now there are several phases to the different Black Swan Research Initiative project, and phase 1 is complete. It's not a phase 1 trial, it's just the first phase of this project, and it was developed sensitive testing methods. So in leukemias, we have this PCR and BCL and all these different tests that can, at the molecular level, detect that there's no evidence in the bone marrow of disease, and that's what we're finding. We think the SPEP and UPEP are sensitive, but there's more sensitive techniques. We want to standardize this laboratory testing across different institutions, and that's complete. We have some wonderful tests that are now available in the United States to determine MRD negative status. Now, the next phase are the cure trials. There's a whole host of trials, and you can learn more about them on myeloma.org on the myeloma matrix. For high-risk smoldering myeloma patients, for example, trying to get that deeper response up front to sustain a remission, preventing them from ever seeing bone damage, never seeing the renal insufficiency, and hopefully they'll have a similar lifespan and good quality of life to other people. So this Black Swan Research Initiative, you can learn more about it on myeloma.org, but it's definitely something to stay tuned. We have many other drugs in development, and this is one of our second to last slides before we do our conclusion slides. And I just wanted to take a moment to share with you that we're not only trying to find better ways to use the drugs we have more immuno-oncology approaches such as CAR T-cell therapy, Pembrolizumab, which you know is an anti-PD-1 that's approved for lung cancer. Ibrutinib is approved for chronic leukemias and Waldenström's. And so we're using the drugs we have and currently developing other drugs as well.
So in summary, daratumumab is a newly approved agent for patients who've had at least 3 prior lines of therapy and who've progressed on IMiD as well as a proteasome inhibitor. Antibody therapies, in particular daratumumab, can interfere with transfusion blood cross-reactivity testing. Carfilzomib has newly approved dosing regimens as well as approved in combination with lenalidomide. Pomalidomide dexamethasone is an all-oral regimen for relapsing disease. And right now, their top researchers are looking for the cure, and we're really hopeful that just around the corner we'll have a cure for this disease. And many drugs are in clinical trials right now, both agents that we are taking from other malignancies, such as pembrolizumab, as well as new agents. And then nurses are key coordinators of patient care among all providers, as well as the extended treatment teams. And they help with educating patients as well as their caregivers.
We're the glue that keeps everyone together, right?
And so in your packet, you have some of the information that we're going to be talking about. So in your packet, as well as on the myeloma.org website, you have all 4 supplements that the Nurse Leadership Board has put together for the care of the patient with myeloma, including the new one from the Journal of Advanced Practitioners in Oncology Nursing. You also have additional resources. You have a USB drive in there that has the articles and then also has the slides from the presentation. You have some tip cards in there as well that you can use. And then these are the website. This is the website for the IMF, myeloma.org. It's pretty easy to remember. And then also you can provide the IMF hotline number to your patients. If they ever want to call and ask questions about myeloma, they have trained staff that is available to answer their questions and help them find clinical trials. On the IMF website, there are also there's just a ton of information out there that you can have for your patients. There's information for newly diagnosed patients as well as patients who have relapsing disease. There's also more treatment-specific patient education, such as information on lenalidomide, bortezomib, Kyprolis, or carfilzomib, and then also a concise review of myeloma. And then also the tip cards, both for clinicians as well as patients.